This is called an obstructive hypopnea, and it's basically the precursor to an apnea, but oftentimes these can have very low drops in oxygen as well, where you breathe fine and then you trail off, and then you breathe fine again and you'll trail off. And these oxygen levels, again, these transient dips in oxygen over time can cause badness to the vessels. This is Cheyne-Stokes breathing, and often something that I'll see in congestive heart failure patients, where they have this sort of periodic breathing almost, where they sort of start off slowly and then they get bigger and bigger and bigger, and then they trail off and they do nothing. And then also the chest is not moving and the belly is not moving, so everything's not moving. So you get these really sort of increases in your breathing, and then you get this central apnea, and then you get the increase in breathing and then just central apnea. And of course this is not good over time, and can be very well treated with CPAP, BiPAP, or BiPAP ASV therapy. So normal anatomy during wakefulness, this is a cross-section MRI sort of through here looking down in. So this is your trachea, this is your airway open, and when you fall asleep it does actually close a little bit. I mean, that's normal. This is also an MRI now, cut through this way, and your airway is right here, this black part, and it's nicely and open. That's your epiglottis right there. There's your tongue right there. These are your vertebrae going down, so it's actually nicely opened. This is what happens when you gain a little bit of weight. Your weight actually, believe it or not, you get fat deposition into the tongue. You get fat deposition into the muscles of the back of the neck. And what happens is this pushes in this way, this pushes in this way, and then now you get a narrowing, almost like an hourglassing of the back of the throat here. This is what happens with no CPAP, and I'll explain CPAP in a minute. And this is when you put them on a little bit of CPAP. Basically, it holds that trachea, it holds the airway open. This is CPAP therapy, where right here you're closing off. Things are relaxing, falling back, and closing off here. And this is pushing air in, and literally it's an air stent. It holds the back of the airway open so that you can breathe easily in and out. This is just another way of looking at it. Closing off here, you wear CPAP, it opens you up, it allows you to breathe deeply and regularly throughout the night. So I'm going to end, I think that's, yep, I'm going to end just with talking a little bit about treatment options. So in a very general term, treating an underlying medical problem going on is one of the things, obviously, it has to start off with. And I think that we probably don't recognize maybe how much can happen at nighttime in terms of breathing and different disease states that we're not necessarily looking for it. And I think that there should be maybe a little bit more of an awareness in general as us healthcare professionals to recognize that a lot of different disease states, Parkinson's, congestive heart failure, stroke patients, they are at a high risk for breathing problems, and they should probably be followed and hopefully fixed, and that may actually help with their sleeping and how they feel during the day. Secondly, there's some, there's research out there that actually supports timed light exposure, sitting in front of a light box, and actually how that can help someone get better regulated and more consolidated sleep at nighttime. Regular exercise also tends to help patients sleep better and feel better. Cognitive behavioral therapy for insomnia is something that I've been working on. I'm trying to find a therapist to join my group and help out with patients who have sort of high anxieties and even just health issues, to allow them to think about sleep and approach sleep in a different way and sort of retrain their brain so that they can actually have better sleep at nighttime. As an analogous idea, children who have night terrors, what they'll do for kids is that they'll have them meet with a therapist during the daytime and have the child recreate the dream, except now they're having the child think about a nice ending to the dream, a happy ending, right? And they do this during the day, and what they do is they do this over and over and over again with the kid, and so then what happens is that the night terrors tend to go down and down and down because they're retraining sort of their daytime thinking not to have that bad dream. So this is kind of the idea that this cognitive behavioral therapy for insomnia, it does work, but unfortunately I don't have anybody yet in the area who does it. I'm looking, and eventually I'll find somebody. But melatonin, as I've already shown you, could be potentially something that we could look at to replace. And then obviously there are a multitude of prescription medicines that I'll comment on in a minute. Okay, so just a few more comments before we're done here. This is just an article that I saw that came out this month. Sleep and regular exercise in patients with dementia and chronic insomnia. They had their patients walk at a 3 metabolic equivalent, and that's sort of mild, maybe moderate walking, biking, or doing some calisthenics. Sleep hygiene education was done for them. They exercised 3 times a week for 12 weeks, and they actually decreased frequency of feeling tired. They improved sleep quality, mood, and quality of life. Not bad. Not bad. I think if we gave people light and exercise, we would improve a lot of people. But we don't have those abilities, I don't think. I mean, you guys can tell me more. I don't know. Here's another one. Bright light therapy on sleep and dementia had beneficial effects on sleep duration, so how long they were able to sleep. They had longer sleep. They had reduced sleep latency, meaning they used to fall asleep in an hour, and now they're falling asleep in a half hour, that kind of thing. Greatest effect was in the winter. Isn't that great? Seasonal affective disorder was improved. But unfortunately, there was no effect on daytime napping, sleep efficiency, or fragmentation. We still saw the fragmentation at nighttime. But I'm wondering if we were to combine sort of the light therapy and the exercise, whether that would actually improve overall. And is this one of my last slides? Yeah, okay, so we're just about at the end. And I just wanted to make a few comments on medicines. So these medicines up here are things you can get over the counter. Melatonin, Calm is actually a magnesium supplementation, and I have patients on that, and they say they do pretty well, believe it or not. This one is just sort of a generic sleep. You'll find them online all the time, and they probably have a combination of melatonin and maybe valerian and maybe some magnesium. Some of them actually are combination ones, but you just have to sort of be careful because anything you buy isn't regulated by the FDA, and so you don't really know exactly. Salmonex actually and Tylenol PM, and those, they have Benadryl in them. You have to be careful because they can cause those anticholinergic symptoms, dry mouth, dry eyes, urinary retention, so you got to be a little careful using those. And then valerian. So the other ones that are prescription are sort of down here, and we've heard about them. There are 5 FDA medicines approved for sleep: Ambien, Lunesta, Restoril, Rosarum, and Sonata. Rosarum is the one that is non-addicting. All the other ones can potentially be addicting. Rosarum is the one that I told you, it allows your own melatonin to hang around a little bit longer, right? They all can help, but if you're on them for a long time, you can easily have rebound insomnia. So you have to be careful. Anytime you use these, I usually you're supposed to use it in combination with cognitive behavioral therapy so that you can get the person, okay, falling asleep, and they get the therapy going, and then take away the medicines, and then boom, they're doing much better. But unfortunately, I don't have that yet, so I try to do a little bit of that myself. But eventually, you want to try to take the medicine away because you don't want to cause the rebound insomnia. So, when to see a doctor? Well, you guys can probably figure it out, but medical conditions all by themselves. You know that there are some increased ones. Snoring loudly, if they stop breathing, if they're feeling tired or dozing off during the day, especially driving. Difficulty with sleep 3 or 4 nights a week. Uncomfortable sensations in their leg. We didn't really comment on restless legs or periodic limb movement, but that can definitely be treated. It often fragments sleep, interruptions of sleep, whether it's bad dreams or pain or heartburn. And in general, these are the benefits of treatment. So I think that's it. Sorry, I only left for a couple minutes for questions. I apologize. So I'll take any questions that you have. What's the bright